Top Med Talk.
All right, well, we are here back, Top Med Talk at Anesthesiology 2018 in the exhibition hall here at the Moscone Center. And we are sitting on the Smith's Medical booth, booth 1519, able to sit and do our roundtable discussions for Top Med Talk. I'm Desiree Chappell, host of the roundtable, and I am joined by Professor Monty Mythen, editor-in-chief of Top Med Talk. Monty, how's it going?
It's going great. We've had a great series of interviews this morning. It's great to be back at the ASA. It's very generous that they've allowed us to be here, particularly coming into this wonderful display of modern industry capability, bringing it to medicine. Great to be here in San Francisco, another wonderful city. Really delighted that Top Med Talk has had such a fantastic year since the last time we were at ASA. Hate to keep banging on about it, but we're aiming for 10,000 downloads this year, and we're close to 100,000 downloads in 90 countries. So there we go.
Yeah,
good to be here.
We are definitely things are taking off.
Things are taking off.
Yes, it's good.
We're going quicker than enhanced recovery.
Yeah, that's true. It's very, very true. So one of the topic for the weekend and theme for the weekend that we had decided on and that we wanted to discuss was enhanced recovery after surgery, and the implementation and utilizing it to improve care of the perioperative patients. So everything we're going to be talking about this weekend is going to be revolving around that. We've been talking to some special guests today. Monty?
So we started off with Henrik Kellett. So we went over the past, present and future of enhanced recovery. So that's already streaming in between these conversations. We've had Rashir Gupta, who talked about the practicalities of being a champion for enhanced recovery as an anesthesia provider in New York, in Stony Brook, in Long Island, who we spoke to in the past. We just finished with VJ.
Yeah.
From where's VJ from? Gone from the
MD
Anderson. Was struggling for his cancer centres, wonderful cancer centre, where we were talking about enhanced recovery for cancer adoption. And Sol Aronson joined them from Duke University Medical Center. So far we've been through, people think it's the right thing to do, implementation is possible, pathways, protocols, patient empowerment. And now I think we're going to have a chat about the challenges of quality improvement programs.
We are with
Can they work, and how do they work one way and maybe not work the other way?
Yeah. So that is leads me to the introduction of our very special guest, Dr. Carole Peden, who is an professor of anesthesiology. Thank you. At the University of Southern California. Carole, thank you so much for joining us. I know that you do some other things there at the university, so can you give us a little bit of background?
I do. I have a title of Director of Health System Innovation as well.
That's right.
So I've been very privileged, having been in Southern California for 3 years, and with innovation in my title, to see a lot of digital innovation, technology in medicine, some very exciting things going on at USC with avatars and the military. So, for example, and this is something that could be applicable in our world, that they find that military vets who are distressed are happier to talk to an avatar, even though they know that a doctor will be sitting behind it, so they will reveal more. I'm thinking that could be applicable ultimately in preoperative assessment. Some very exciting things that I've been privileged to see in that environment.
So for the avatar naive individuals, everyone would have looked at them, but these are the cartoony type of figures.
They're quite sophisticated.
Okay.
There's a lot of funding going in through the US military, and obviously the USC has a big cinema school with the movie industry in Los Angeles, so they're pretty sophisticated, and they also use artificial intelligence to filter questions, so it's very exciting stuff that we probably should look at in our world.
So they have emotional changes on their face.
Yes,
but
they can also read emotional changes.
Wow. We need some more doctors who can do that.
Yeah. That could definitely change the way all of us are practicing, for sure. Well, that's great. I would love to talk to you more about the innovation piece of that. We talked to Professor Kellett this morning about enhanced recovery, and he's an innovator himself, and it's always kind of looking forward in tech. So I think that bringing these innovative technology.
But I also think some things I've written about, a couple of pieces in New England Journal of Medicine Catalyst in the past couple of years, is the patient empowerment, and with apps or pathways the patient can download and input their information in, which they own. So you get around some of the HIPAA issues. We can collect the the data that, what matters most to the patient. Am I back at work? How am I feeling? All those things that we've struggled to collect can be facilitated by some of these apps and applications that you can get.
So Professor Kellett was touching on that, Henrik was touching on that this morning, is that one of the big challenges is still to work out if the patients are better.
Yeah.
So if it's a knee replacement, for example, I know we keep using that example in Top Med Talk, apologies to knee replacement surgeons if you think we're picking on you,
but
it's a common procedure, is, my knee's better, but I'm not better.
Exactly.
Actually, my knee's better, and I'm worse.
Yeah.
Is the real
challenge.
So
the outcomes that matter most to the patients, the what matters to you piece. And that's another thing I've been working on with various programs in California about getting to what do you really want and value from this procedure.
Yeah, for sure. We had a conversation with Eric Schneiderwind, who is the president of the AARP, and it was about that. We need to engage the people that we're taking care of and really find out, what matters, and finding ways to do that. Not everyone wants to talk to a physician in that way.
We've done some simple work, again, with some orthopedic patients, just putting the follow-up after surgery question slightly differently, more like a consumer survey about what could we do better, what matters to you, and a lot of very interesting feedback about how we could improve pathways, which is different to when you ring a patient and say, how's your wound, how's your pain. You're directing the questions, open it up more, and, allow the patient to be more expressive about how they're feeling, and you get a lot of useful information.
Can you give us a few gems from that?
Well, the thing was, for example, I think patients find, there was a lot of things like they found some of the discharge information confusing, and we looked into how we could make that better. We found that we can easily, with our pharmacy, do infograms, visual pictures of these are your take-home medicines, which patients like the idea of. And even things after a joint replacement about talking about you're going to walk straight after surgery. Patients find that confusing because they think they're going to walk normally. So just reframing it, that we're going to help you take a few steps, it will get better each day, puts it into something the patient can handle, and they have more realistic feelings about what's going to actually happen to them.
Yeah.
And can you match the information to the patient? Because we're all a bit different. It's like some people like infographics and other people like equations. What's the
Well, that's another piece of work, isn't it? What demographics do you do? If it's millennials, what do you do with them as opposed to 80-year-olds?
Yeah, that's right. Well, and really being able to utilize that through the entire pathway and from the moment that you talk to them first in the office, and that's really added benefit. So we're talking about establishing protocols and pathways.
Okay.
And I know that you've done some work recently. You guys, you just had a patient, a publication very recently, actually, a study called EPOCH.
Well, EPOCH, the publications aren't out yet, but very excitingly, it's been accepted by the Lancet.
There we go.
Oh, it's been accepted.
It's been accepted.
I just saw that.
Also by Improvement Science, which is more a deeper methodological paper in the background. And also we had another one in Sociology, Health and Illness, which is, a place as an anesthesiologist I never thought I'd be published, but that was the ethnographic study. So there's a lot of rich learning. I think when we announced the results at EPOCH, people felt perhaps disappointed that there wasn't, we hadn't shown that this quality improvement study had impacted our primary outcome, which was 90-day mortality. But actually, when you look at the study was powered for 25,000 patients to detect a reduction in mortality from 25% at 90 days. But actually, the mortality in both the intervention group and it was a stepped, wedged, randomized controlled trial. So patients were compared before and after quality improvement. And the mortality was 16%. So to come down from what we'd expected to see. And I think this is an interesting thing with quality improvement programs. And this happened with the Matching Michigan study in the UK as well, that there's a background improvement going on that can sometimes be hard to, something has driven improvement with these patients in the UK.
So I'm just going to repackage that again for a second. So when you designed the trial, the assumption, the data at the time suggested that the mortality rate
at 90 days
was 25%.
Correct.
So 1 in 4 patients was dying.
Yes.
And you were hoping that by this intervention, that in the one limb that got more of this quality improvement intervention, you would drop it to what level?
22%, I think the study was designed.
So 25% to 22% was what you were hoping for the intervention limb. But overall, it went from 25% to 16%. And do you think the 16% is representative or just in the trial?
Well, if you look at the NELA data, or if you go back to when everything started in the UK with the original National Emergency Laparotomy Audit, which is an audit of all patients undergoing emergency laparotomy, emergency intra-abdominal surgery in England and Wales. When that started, the first patient year data was the mortality was 11.9% at 30 days, and that's now come down nearly 2%. So there is a background improvement. Now, EPOCH we were comparing patients, it was quality improvement. You were comparing hospitals in a group before and after the QI. So we didn't see a dramatic difference, but we did see some improvement in process delivery, and we did see good engagement with quality improvement. And one of the things we were trying to do with the EPOCH study, and I think this is very important, is to reframe the problem as a social issue. In medicine, we often think as looking for technical innovation, the new drug or the new procedure. What we were trying to do with EPOCH was frame it as this is really a big problem, and we need to change how we talk about this, how we think about this, how we think about these patients. And one of the key things that we saw was that hospitals that had where the leadership was well networked, they had senior leadership support, they were more likely to be successful than where the QI leader, the quality improvement leader on their own, was trying to do everything themselves. They hadn't been very successful in engaging other team members. So I think that's one thing. Start with a team. Get the senior leadership engaged. And the other really key finding of this study was we were trying to get a 37-component pathway implemented. Some hospitals at the end only had 5 weeks to make change happen. Yeah. And in fact, those at the beginning, EPOCH started just 3 months after the start of the National Emergency Laparotomy Audit. And so teams were really struggling to see how they put their data into the audit. So they were focusing on the data collection, not on the improvement. So the things that we saw were, although we had good engagement, people liked what we were trying to do, there was an awful lot of disruption in their hospital backgrounds, a lot of change going on, and they often didn't have time to do this. Even at the end of the study, only 50% of hospitals, by the end, so after 85 weeks, only 50% of the hospitals had any kind of way of collecting the NELA data prospectively. So there was, I think our learning would be, in future, make it more simple, allow more time, really emphasize what you need to do to engage leadership and your colleagues, and how, and give the clinicians we're asking to lead more tools to and more coaching on how to make that happen.
So if I hand back, I think you said there were 3 papers. So there's the main paper coming out in The Lancet.
Yes.
And do we know when that's coming out yet?
No.
Okay.
And let me stop real quick, because I don't think we officially define what EPOCH
is.
It
was, and I have to particularly, there was a big study group. It stands for Evidence-Based Peri-Operative Care of the High-Risk Surgical Patient, but it was focused mainly on emergency laparotomy.
And if people go into Top Med Talk and go to the search engine, so if you're not a subscriber already, subscribe to Top Med Talk, go into the search engine. There's also, you can get via the subscription, you can get into our app as well, and put in EPOCH. And I think there's not only the live presentation from EdPom London, there's also some follow-up discussions that go into the details. Yeah,
Rupert and I and Joff were actually able to sit down with, Rupert and talk to him about the study and do a deep dive into it.
I think I would have to call out Rupert Pierce and Tim Stevens.
Yeah, that's what I was
as my colleagues on this. And Rupert, is a great scientist and designed a very good study. And also, I think, we had ethnography. So we had Graham Martin's team looking at, the reason I can speak quite confidently about some of the issues in the background is that we had formal ethnographic study. So that's an anthropology in medicine, if you like.
Which I think Rupert described as why doctors are so difficult. Is sort of so one paper is the Lancet paper, which is the headline results.
Yes.
Now, is the ethnography component of it
that's the one papers? In sociology and health, and the first author on that is I think it's Graham Martin, and the third one is improvement science.
Okay.
And that's
fantastic.
That was accepted on the same day as the Lancet paper, so hopefully it'll be about the same time. We probably, Tim Stevens and I are looking to write another paper on actually looking at the processes that change, because people did improve processes.
Right.
Obviously not enough and not at a big enough scale to impact our primary outcome, but things did improve. So it's pulling out the learning from that, who improved and why, and why did others struggle so much? But that's, again, tied up in some of the ethnography we've already written about.
I promise my last question, because I'm hogging this.
No, it's
did the dose of improvement track in some way to the amount of improvement results? Okay.
No, it didn't.
Okay,
interesting, yes. Because you could argue that, well, and if you look at studies of quality improvement collaboratives, it's a sort of 1/3, 1/3. So 1/3 of teams will not engage, 1/3 will kind of be average but won't show much change, and 1/3 will do well. And I think in this design of the study that might have happened, but again, the dose and response was not enough.
Really interesting. A bit disappointing.
Well, obviously I would have loved it to be highly positive, but I think there's so much learning from it that we shouldn't lose sight of that. And I think getting that message out there in a sort of an opinion piece or something about what we learned, what we would use to take forward to further improvement and implementation studies that perhaps we've learnt from doing this.
And congratulations everyone, because at the end of the day, if the mortality rate went from 25% to 16% over the EPOCH, the time period, wow. 9% absolute reduction.
Yeah, and
in not relative. That's extraordinary.
And also look at NELA is showing year-on-year improvement, and so something is driving the fact that we're getting better at delivering care to these very high-risk patients in the UK. And I think Rupert Pearce was amazing at driving the energy around this study. People were talking about it. The same with the emergency laparoscopy collaborative earlier on, EPOCH. So I think the fact there's been all these studies that people are talking about, and of course the National Emergency Laparotomy Audit, people are thinking about it. There's a degree of Hawthorne effect. But at the end of the day, more patients are surviving.
Yeah, that's fantastic. Speaking to just getting people excited and engaged and pulled in, I think is really important whenever you're talking about, all these the bigger studies, but also kind of what we have to use in our quality improvement programs.
And I suppose again that's another disappointment, because there were 93 hospitals in EPOCH who worked really hard, and I would have loved it to be successful for them. And a lot of them, we asked them to reflect on what they would keep doing, and they would keep doing improvement. They keep thinking in a more systems oriented way, and they would like more knowledge of how to engage and with leadership and colleagues. So again, there was a lot of things people were very positive about, but also things that they would have liked more of or to do differently.
Well, it's great that it opens up the conversation too, for them to start in there. I mean, maybe it is that they reduced their protocol down to 5 items instead of 31, and so just having that open communication with others, I think, is probably pretty important as well. Slido questions. Do we have anything good up?
No, I'm going to save the ones we've got for now, but I do want to look back, because we've been talking about quality improvement in general. Yeah. And EPOCH, in a way, was sort of enhanced recovery for... One way of looking at it was in elements of enhanced recovery for emergency laparotomy patients. Is that fair?
I think so. I mean, it was a complex pathway, which, I think, correct me if I'm wrong, it was 37 components in EPOCH, and there's about 37 components in a standard enhanced recovery pathway.
Because, again, hate to keep harping back to our conversation with Henrik Keller earlier on today, he said originally when they did it, there were 5.
Well, that's where, of course, with EPOCH and the Emergency Laparotomy Collaborative, there were, 5 or 6 components we want people to work on. Yeah.
And the 5 for the emergency laparotomy is things like cracking on and making a diagnosis and giving the antibiotics and getting the right people in the room, and then some very basic enhanced recovery principles about recovery. But 5 seems to be about the most that people can cope with.
Well, I think also remember one of the important things about quality improvement and collaborative learning is that synergy that when you get everybody in the room talking about what they've done, and that concept of borrowing, that's a great idea, can we try it too? And I think if you've got 37 things going on at 93 different sites, it's really hard for people to be having those conversations, because everybody's doing something different. Yeah. Whereas if you distill it down to a few components initially, and as you get more sophisticated, perhaps you want to branch into others.
Yeah. So there is a Slido question that is pertinent that's been voted up to the top. To remind people, if you go to Slido, slido.com, and you put in TMTASA18, how does anesthesia convince surgeons to change their ways?
Yeah.
Well, I presume that comes out to a certain extent in the ethnography. And it's not just surgeons, is it? It's how to get people to change their ways.
Yeah, I think that was one thing. Some of the teams had surgeons engaged in the beginning and then they dropped out. And I think there was still a feeling that EPOCH and even the National Emergency Laboratory Audit is an anesthesia thing. So I think surgeons can be very engaged, but you have to make it very relevant to them. And again, I would go back to the data. Get the data. One of the things we did actually that was very effective at the first EPOCH engagement meeting was ask the teams to look through 2 to 5 sets of records of patients who'd undergone this procedure and, you know, have their gold standards of things they thought should be done every time. And the number of clinicians, and particularly the surgeons who thought, I thought these things were happening for my patient, but they're not.
Yes.
And that was a really good way to get them engaged.
Was there much you had to convince them of, or was it just them saying, yeah, sure, get on and... Yeah, I thought you said, I thought you were doing that. You don't have to convince me that's a good idea, is it? There must have been a mix of the two.
There was, and again, the complexity, I think, again, if you distill it down to a few things people can focus on, it makes it easier. But showing or allowing them to demonstrate to themselves that these things weren't happening as reliably as they thought they might be happening was effective.
Yeah, getting the data is always going to be the primary driver there. And I would say that some surgeons would say that how do we convince our anesthesia colleagues to do it in reverse? I know in the U.S. sometimes it's anesthesia, sometimes it's surgeons, you know, and I think probably the ethnography applies to us all.
Are there any big messages from the ethnography study that are simple to translate in a few words now? Or?
Well, one of the things that came out was... I think the ethnographers went in with the social hypothesis that doctors in particular don't like to be constrained by pathways or protocols. But what they found was particularly in these complex emergency patients, and particularly if you were a surgeon who's normally doing breast surgery and you have to face a laparotomy, having some standardized care pathways was very, very helpful and facilitated the conversations, for example, at the end of surgery about where should this patient go. You had a standard pathway which said send them to, you know, a critical care bed. And so that came out as being very helpful, particularly in this complex environment.
Oh, very
great.
Good. Yeah, very good. So we are coming to the end of our session here at Anesthesiology 2018. We're Top Med Talk coming to you from the Smiths Medical booth at booth 1519. And Carole Peden graciously gave us some of her time. I know that you've been super busy with some other initiatives that you're working on.
Off to the Brain Health Initiative.
The Brain Health Initiative, which we're going to be actually talking to Lee Fleischer and Sarah Locke from AARP about the Brain Health Initiative coming up next at 1:30. So please sure to join in. Monty, are we going to have some lunch in between here?
Yeah, but just to remind people, don't forget to subscribe. And if you're here at the ASA listening, as we know lots of you are, as you walk around listening to the live stream, is if you subscribe today and you submit, we'll enter you into a drawing or raffle, and there's this lovely Marshall speaker that we're using on the stand that you can walk away with. Yeah. Great British product. Jim Marshall from West London, made in China, designed in Sweden. Yeah. There we go.
International speaker, global speaker.
Global speaker, EPOM International Endeavour. Yeah, thanks everyone for listening. Talk to you again soon. Carole, thank you.
Cheers, Carole. Thanks so much.
Top Med Talk.